So, good evening, ladies and gentlemen. I'm Isha Narwan, your host, and I would like to render you all a very warm welcome to AIOC 2021. Without any further ado, let's get started with the session. I would request the chairpersons to please unmute and switch on the camera, starting with Dr. Colonel Madhuria ji, Dr. Mohit Sharma, Dr. Swati Tomar, Dr. Zamina Samina. Also, I request our moderators to kindly take over from here. Dr. Aarti Nangia and Dr. Maya Hada. Please, over to you.
Good evening, doctor, from scientific committee team. It's 85-minute session, doctor, and there are 17 speakers. Requesting doctor to stick to 5 minutes each so that we can end this in time. Thank you so much.
The session is going to be of 5 minutes, ladies. So, yeah, everybody, all the best.
I think the time's been prefixed. Some speakers have 3 minutes and some have 6 minutes. Could you please check?
Yeah, that's
no issues, madam. No issues.
Doctor, redo the slides now.
No issues.
Yeah, still, but we are a long list. So,
Yeah.
right,
So chairpersons and moderator within yourself, you can take them. It's 85 minutes. Thank you. Please.
Thank you, Isha. That was very sweetly introduced. Good evening, everybody. And it's very nice to be on this academic platform. And I welcome you all this eve for a session, which is Science, Skill, and Beyond. I'll have my pretty co-host with me and rather a convener, a very, very acclaimed prolific surgeon, Dr. Maya. And since we have to be really on a little hurry mode, so I would want this session to stick by the time. Whoever has 5 or 3 minutes, just go ahead with that. So I welcome our chairperson, ma'am, Dr. Madhuria, Dr. Mohita. The rest of the whole list will go one by one. Science, Skill, Beyond. Launching ourselves in any non-research career doesn't mean that leaving behind everything you learned as a scientist. The skills you developed as you dove into projects and communicated your results are all valuable in our jobs. So with this note, this is a session with a lot of variety of what practically we do and what research is going to augment our knowledge with. So I am going to open this session and introduce my very coveted chairperson, ma'am, Dr. Madhu Bhaduria, ma'am. She is our president. She is the WAS president. She is a graduate and a postgraduate of KGMC Lucknow, a fellow of Shankar Nethralaya, Chennai. She has worked with the armed forces for 25 years. She joined the Regional Institute of Sitapur Ophthalmology Institute as a director and chief medical officer. She transformed into this hospital into a vibrant hospital with a large community volume work and subspecialties. I would want ma'am to speak a few lines and join us and make this session go ahead.
Aarti, it's always a great pleasure to be with you all. The time I truly enjoy. And it's like home. So I don't know actually what you really say to your people at home. But all I can say that the way WAS is growing, I have no reasons but to be proud of WAS. So many activities are going on, especially in the area of research, women development through DSSC projects for women, supporting each other, showcasing each other, building the skills of people, and the newest of all that we are going to have a issue of the red eye diseases in January. So I think all those are really great things, and you girls are doing really well. And not one, I think each and every member of WAS is contributing in some way or the other, either in the WAS activities or in clinical practice, or in both. Or I would say not in both, in all three, because the homes are such an integral part, which is truly a lot more women's responsibility than the responsibility of men. So I think all the girls are doing well. I'm very proud. I wish you all the success, and keep going, rather keep moving with a speed the way you're moving. All the best.
Thank you so much, ma'am. They were very appropriate words at this time when WAS's hands full with a lot of newer things in the basket. Our chairperson, ma'am, Dr. Mohita, she's our secretary, a very dynamic one, and with full of thoughts and ideas. And I think she's launching one after the other programs. She will be joining in a little later, and then I will introduce her. I would pass the baton to Dr. Maya. She's a RPC alumnus. She's an assistant professor at the SMS Hospital, Jaipur. She's a very, very, good acumen oculoplasty surgeon. And I heard she's doing a lot of Mucor, and she's saving so many lives and eyes, through that. So Maya, all over to you to introduce the rest of the speakers.
Thank you so much, ma'am, for those kind words. So I'll quickly move ahead, and we have with us our co-chairpersons, Dr. Samina Zamidar and Dr. Swati Tomar, who are two of the founding members of WAS, and Dr. Samina is also a state head chapter of Karnataka, and she is the well-known NABH assessor and a trainer, while Dr. Swati is heading the state chapter of Rajasthan, and she is also the medical director of Eye Bank Society of Rajasthan. And we have eminent panelists with us. I think we have Dr. Sudipta Ghosh has joined, and Dr. Alpa Atul has also joined. So Dr. Sudipta is the state chapter head for West Bengal, and Dr. Alpa for Telangana. So we welcome you all. And also with us, we have Dr. Aarti, the co-convener. She is the state head for the Haryana chapter, and she is also the head of ophthalmology at Site Avenue and Fortis Escorts and Fortis Vasant Kunj. So I'll go ahead with the first talk, and I'll ask Dr. Aarti to introduce our first speaker, please. You are muted, ma'am.
So our first speaker is Dr. Mohita. She is going to join in a little later. So I'll just plunge into the next in the lot. This is Dr. Soumya. She is she's presently working as a director at the Lopamudra Drishti Eye Hospital. She is honorary secretary of IMA. Very enterprising in such a young age. You are an IMA secretary at Virajpat Kodagu. She specializes in cataract and refractive surgery. Fellow from Narayan Nethralaya, Bangalore. I know her, and I know she's superb in her work, what she's doing. We want you to talk about eye care to COVID care. I know COVID swamped us through like a tsunami. And when I say eye care and COVID care, along with the etiquettes of COVID safety, eye safety is all what you're going to talk about. Let's hear you out.
Thank you. Am I audible?
Yes.
Yes, thank you. So thank you, Dr. Aarti, and a big thanks to AIOC and WOS for making this possible for us to meet on this virtual platform today. And it's my great honor to share our work on COVID right here from Coorg. So we know in India, we've both celebrated our initial victory and then mourned our great losses during the second wave. And I am speaking from Coorg. Coorg is a district nestled in the Western Ghats, mostly amongst forests and plantations. It's the least populous district in Karnataka, but it's also marked by extremely poor health infrastructure, which is one of the reasons why we moved to Coorg. We are Kodavas, so Kodavas are the earliest inhabitants. We are mostly a warrior community, and we're also agriculturists. And when COVID came calling last year, the then deputy commissioner called us in for a meeting. And she said, just like in Italy, Coorg has a lot of elderly population. And if we remember, we saw a lot of deaths in Italy last year during the first wave. So she said that is going to repeat in Coorg. People are going to fall in great numbers. But God and Goddess Kaveri's grace was on us, and we remained in the green zone for the longest time. But of course, the reality of the poor health infrastructure did not go away. But once the lockdown opened, people started traveling, children started coming back, they started working from home, and there was a lot of inter-district travel. And by the time the second wave came, people had thrown caution to the wind. In April, we were one of the worst hit districts in Karnataka. But even until April 2021, the only COVID center in Coorg was in Madikeri, which was a government center. There was no facility in South Coorg that people could go and get admitted in. And to give you a perspective, if somebody from South Coorg had to travel to Madikeri, which was the only COVID center, they'd have to travel 84 kilometers. And this is along the sinuous roads of the Western Ghats. So this is definitely not an easy feat to do, especially if you're gasping for breath. So this is when we decided to set up a zero billing COVID center, because we knew it can, COVID, if you get admitted and you pay for it, COVID can just wipe out your savings like that. So we knew that we would, get some amount of criticism. We would have some difficulty, but this was a time for us to be there for our people and our community. So we decided to go ahead and take a leap. For people who don't know, COVID care is in 3 tiers. One is the COVID care center. This is where you would host the asymptomatic or stable patients. The dedicated COVID health center caters to patients who need oxygen, who need some amount of attention from the physician, but are not on the ICU. And then the worst hit would be the COVID ICU, where people are extremely critical, and like we know, the mortality is much higher in these people. So we are a dedicated COVID health center. We did not want to set up an ICU because there is no intensivist in South Kodagu. Only the medical college in Madikeri has an ICU because they have access to intensivists. There is one anesthetist in the government sector, but of course, we can't run an ICU, on 1 or 2 people. So this is our hospital, and we had a beautiful yoga hall on the 3rd floor. So what we did is we decided it was more important for us to be there for our community than to have a yoga hall. So we converted the entire 3rd floor and the adjacent wards into a COVID health center. Our 2nd floor was a buffer zone. The 1st and ground floor remained to be our regular patients. We were catering to our regular patients. And to prevent intermixing between the 2 people, we separated the entry for both kinds of people. So COVID patients could access to a separate entry. And we were fortunate that our land is slopey. So we had a separate road where the COVID patients could go directly to the 1st floor and then via ramp to their COVID health center. So I don't even want to start about what things we had to put together. It was literally like starting an entire hospital along with, the permissions from the government. And this we had to do in 10 days in the middle of a pandemic and the lockdown, with all the cost of medical equipment skyrocketing at that point. But we did have a lot of help. A lot of local people came in and pledged their support. People, Kodavas abroad, they sent money via Karuna Trust. And because we as a hospital, we didn't want to handle, people's money. We didn't want to handle donations because we wanted to be extremely transparent about it. We did not accept any donations, but they were all directed via NGOs, local and otherwise. And even Narayan Netralia supported us. They sent us a 10-liter oxygen concentrator right in the beginning of our project. We were very fortunate to have 2 very eminent professors from the University of Florida support us. So every day, each patient is discussed with these professors, and one of them is even an infectious disease specialist, and they've had a lot of experience dealing with COVID. So this has really helped us in the way our outcome has been. So we used only therapies proven by RCTs. Patients got oxygen. They got steroids if their oxygen saturation was falling, and all of them got prophylactic heparin. Nobody received medications like ivermectin or doxycycline. Patients received remdesivir if they were within 7 days of onset of symptoms and after scoring on News2. So News2 is even available online on an app called MedCalc. And if patients had anything more than moderate to high risk, and if they were within 7 days of symptoms, they received remdesivir. We did not have access to repeated CT scans, and that was done only at the beginning during admission. And we didn't do expensive tests like ferritin or interleukin-6 because it was a free center and we wanted to keep our costs low. Antibiotics were not used for COVID pneumonia and were used only in 6 patients. And we are very proud to share that our mortality is less than 2% in our center. So far, we've referred only 3 patients to an ICU, and we had 1 in-house death, and that was mostly for palliative care for a patient who was already suffering from a lot of illness, and they were sure they didn't want to go to an ICU. Food was probably one of the most difficult things to cater for COVID patients, and probably we found it easier to treat the patients than to live up to their standards of culinary taste. Different people have different expectations, and you have to cater to all of them. And as of day before yesterday, we started vaccinating our people. And in the last 2 days, we've vaccinated 530 patients. And this has been the highest in our district to be done by any one center. And the most important takeaway point is that it is very important to watch out for the fall in SpO2. So if your SpO2 is about 98 normally, and then if it is coming to 95 or 94, even then you should watch out and seek attention. So this is the end of my talk. Thank you. This is Coorg. This is where all the magic happens. And once the pandemic ends, you're all most welcome to visit us.
Beautifully put, Soumya. And I'm absolutely amazed at the kind of mortality, low rate, and beautifully how you managed COVID like a physician. I think, you did a wonderful job. And now you are vaccinating. I think we are going to save third wave only if we go ahead with this kind of a attitude,
Yeah.
So, I feel Dr. Mohita has joined in. Maya, can you see her?
Yeah, she's here.
She's there? Yeah.
I had a question,
Dr. Mohita.
Dr. Sonia. Are we ready for
Hello.
questions? Or
No,
are
we'll take them. Sudipto will take them a little bit later. It's a little packed up session, little packed up. So, Dr. Mohita, I welcome you aboard, and she is the woman behind everything, including the session. She is she's our secretary, and she is a Maulana Azad PG graduate and a PG and an ICO fellow in vitreoretinal from University of Regensburg, Germany. She's founder and chairperson of Tirupati Eye Center. She's very dynamic, and I personally am very impressed with her ways and thought processes. She's going to talk about looking beyond lockdowns. Who better than us know about lockdowns, the curfews, and the kind of, the sudden backup of businesses. And when we say lockdown, I think that is what saved us, because it was basically isolation. It was to do with contact tracing, and it was to do really a very stringent way to go ahead with vaccines. Dr. Mohita, all yours to talk about it.
Thank you so much, Aarti. And an amazing talk by Soumya. Really, really inspiring work, and very, very impressed with whatever she did. And in fact, COVID is something which shook all of us. But there are some of us like her who actually took it and started working towards it. And it's really very, very inspiring the way you could do it. Now, what I'm talking about is a kind of a similar topic, looking beyond lockdowns. I'm just sharing some of my experience as to what I have been up to during lockdowns and COVID period in the last 1.5 years. So COVID times were difficult times for everybody, and we all started thinking as to what we should do. And whenever there are difficult and challenging times, we had lots of time also. So difficult and challenging times tend to make us a little selfish, because it is ultimately the survival of the fittest. And we start looking at what we could do for ourselves. So this is one time that I realized I also started thinking, how should I improve my profile further? And two things came into my mind last year. One was that research is like an unfulfilled dream, and let's start looking at research, and let's build our hospital more towards research. And second was, I was already the secretary of Indian Medical Association Noida chapter, which is a lot of gossip and a lot of work, but also a lot of limelight. So I thought, let me hog a little in this limelight, because there is an opportunity also. These were truly my thoughts. And so as I realize now that challenging times do make you a little selfish. So we started working on writing some articles and publications, which was never there in our profile. And Neha is also here. So me and Dr. Neha were the only ones left in the hospital, because most of the people disappeared also, because some were scared of COVID, some got COVID, etc., etc. And we thought, we don't know much about publication, but let's try. And we started doing this. And to our surprise, in the last 1.5 years, we have 7 published articles in index journals. We set up our site for trainings, and we did a lot of, we read a lot about research. And today we have 4 research projects. 2 of them are clinical trials. And we have an invitation for 1 book chapter, which we are writing. So we thought, overall, we thought we did well in the last 1.5 years. And this is what we were looking for. However, when all this was, while you are trying to improve your profile, there is something which comes to your mind, and that is what I call beyond duty. And for me, call beyond duty is always Women Ophthalmologist Society, or WOS. As we started working towards research, we started working towards research in WOS, and I'm very, very happy and proud to be projecting this slide, because WOS started working towards DST projects, and it is the first time that government is honored WOS, and because of this research interest of ours. And first and foremost, I've put the picture of Dr. Neha Jain, because she's, I would say, I give her all credit for everything that happened. And these are the three ladies, Dr. Nisha Chauhan, Dr. Mezabeen Rahman, and our dear own Swati Tomar, who were awarded with these DST projects. And it was really amazing. And this was, better than what I could have ever thought that I could have built up on my profile. So this was like something which was like the biggest achievement. This slide is, I would say, my biggest achievement in these 1.5 years. And we also got a special issue of Red with IGO, which was again a very big, I think is a very big responsibility, but very, very big achievement for WOS. So I always feel that something which is for others always gives you more happiness than whatever you try to do for yourself, though you always try with your own self, and then you realize, okay, the happiness lies somewhere else. Secondly, let me come to Indian Medical Association. As I said, I started working a lot for IMA, and IMA means a lot of coverage in newspapers, Hindi ones and some English ones also. And my family members were calling me up and saying, wow, you are in newspapers everywhere. And I was feeling happy. But then something called Call Beyond Duty came, which means that I found that some of our members were suffering like anything, because there were, the government policies were still not built, and they were being penalized. So I thought, let me go beyond myself and hogging all the limelight, and I took up a fight with the authorities. I had a fight with the DM. I had to fight with the DM of Noida. I had to, write a letter to the chief secretary, and everybody said, why are you doing this? You are, unnecessarily, you are going into the bad books of all the big wigs. So, but then I realized that no, this has to be done, and change did come. Everything, whatever we asked for, they listened to it. And again, the newspapers, but this time the newspapers didn't make any difference on me. Then secondly, this was last month itself. Again, one politician wrote against our members, and everybody said, don't speak up. But I said, we have to speak up, because this is what we are here for. And I was even told that you would be murdered because you are speaking against an MLA. I said, let me be murdered, but I am not happy like this, I just, when people are speaking against doctors who are supposed to be COVID warriors. And ultimately, this was also set right. And finally, the realization in all these lockdown periods was, money is not important, fame is not important, taking a call is important, and a small change that you can bring in adverse situations is the most important. And when you work for others with a good intention, indirectly you yourself also get benefited. So these small changes are the changes which are the call beyond duty, and these are the ones which will actually make a big change in the world. Thank you so much.
Thank you. Thank you very much, ma'am, for sharing your experience. And this is so inspiring for all of us. And that the correct saying is that when there is a will, there is a way. So you have proven that. So we'll take comments from our panelists towards the end, and moving on to the session. And next, I'll invite Dr. Ritika Malik and for her talk, because we have Dr. Janin is having some issues with her internet, and Dr. Namrata has not yet joined. So Dr. Ritika, are you ready with your presentation? You can start sharing. Dr. Ritika is a cornea and a cataract surgeon from Narayana Netralaya, Bangalore, and she has a special interest in corneal imaging. And today she will be speaking upon the imaging of corneal epithelium. Dr. Ritika, it's all yours.
Hello, everyone. I'll be sharing my screen now. Right. I hope it's all visible. Okay. So good evening, everyone. And thank you, Boss, for giving me an opportunity to present my talk on imaging the epithelium and nerves. So let me jump into
PowerPoint
it.
is not visible, Dr. Ritika.
Just a minute. I'm sorry. I'll just share it again.
Yeah.
Okay.
Yeah.
Sorry for the delay. So I'll jump into the talk and let's see how do we image the epithelium. So literature shows that epithelial mapping significantly impacts our safety and efficacy of refractive surgery. And this also allows for significant improvement for therapeutic procedures. So what are the devices available for measuring the epithelial thickness are a few of the OCT devices, RTView, the OptoView, the Cassia 2 device, and the Placido and the OCT-based hybrid topographer, which is MS39. So a few of the maps we see on the MS39 of importance are the epithelial thickness map, the anterior elevation map, the stromal elevation, the posterior elevation map. So coming to the corneal nerves. So how do we see the corneal nerves? This is what a normal corneal nerve structure is present in our body. I'll not go into details, but how do we image it is by confocal microscopy. So confocal is based on the principle that a single point of tissue can be illuminated by a point light source. So this is how it comes in the same plane of the camera and the tissue. On the confocal, this is how we see our healthy nerves. And this is the healthy nerves. What we see are good nerves. And this is how the immature dendritic cells are present. So the immature dendritic cells are classically without any tentacles or wings, flat-like. Okay. So how do they mature? They mature into fan out as having tentacles. So these are the mature dendritic cells. And we can see very poor nerves, which are like feeble lines here. And most of the symptomatic cases, like the pain without stain cases, are the ones with the microneuroma. So what is the importance of corneal nerves and refractive surgery? So we at Narayan Nethralaya have started seeing the impact under an umbrella of a study known as Nirvana study, which is nerves impacting refractive surgery, vision, aberrations, regeneration, and adaptation. So under the Nirvana study, we try to profile our patients preoperatively and then see the effects, how the corneal epithelium and the nerves is regenerating after refractive surgery. So let's see a few of the cases. So these are 3 cases, which is preoperatively, they have a very healthy ocular surface. They have normal meibomian glands. They have normal nerves on confocal. So a regular epithelium, and they have not symptomatic, and the OSDI is also very healthy. Next, see a second set of patients. These are 3 patients who have meibomian glands drop out. The nerves are also very febrile. There are dendritic cells, immature kinds on the confocal. But the most important thing is they have irregular epithelium also. So what happens if we start to operate on these patients? If we go ahead and operate, they will not fare very well, the third set of patients. So let's see how they do. So as you can see, the first, second, and third patients who had a good, healthy ocular surface pre-operatively, even after surgery, they are doing very well. The second set of patients, the fourth, fifth, and sixth, have a high OSDI score, and they will land up with more abnormal nerves post-operatively. And also for the epithelium, the second set of people will have an irregular epithelium picture post-operatively. Leading to all this will lead to a poor visual outcome. And this can be seen by the OCAS machine, which gives us a bad visual film breakup time. So how does wound healing in refractive surgery leads us to seeing how we are doing after a surgery? So on comparing a normal patient who underwent a LASIK and a smile surgery, these are the real-time images which we have turned it into a video over the time lapse. So over the 12 months, we can see that the smile patient who underwent a smile surgery recovered much faster, and at 6 months, the normal architecture was resumed. And on the other hand, the LASIK patient showed a slower nerve generation and a steady growth completing over a year. So what happens when we operate on a patient who has ocular inflammation? So in the same way, the LASIK patient is also showing a very, very poor nerve regeneration, okay? And the smile patient shows a better recovery. So how does it translate to our clinics? That as we can see, the visual breakup time is very bad. Okay, so even if we are doing LASIK in a normal patient, comparing it to a smile surgery will give us a poorer visual outcome. How does this impact a surgery? So a high OSDI indicates an unhealthy ocular surface, which leads to poor nerve regeneration and wound healing, which then leads to poor optics and symptoms of glare and halos, thus making a very unhappy patient post-operatively. So we must be careful to see the signature of these procedures. So every procedure has their characteristic signatures, such as a PRK. If we have an inflammatory outcome in a PRK patient, it will show us as haze. In a smile or a LASIK patient, it will lead to ectasia. So what can be done to prevent this? A thorough preoperative workup and evaluation can be done to prevent this, to take an OSDI scoring chart, to ask for contact lens intolerance, to see the epithelium irregularity, to see the serum vitamin D3 levels, to do a thorough confocal microscopy, to see and so this is how we grade our dry eye disease on mild, moderate, and severe disease. And what can be done to treat our mild cases of dry eye? Pre-operatively, we can put them on osmoprotectant drops and cyclosporin and treat them. After the treatment, after 4 weeks, we can go ahead with surgery. Post-operatively, steroids are important, osmoprotectant drops and vitamin D and cyclosporin. Coming to the future, in the future, we have now developed a point of care diagnostic kit. So this is a short video showing the workflow of a diagnostic kit. The diagnostic kit is actually to customize the treatment outcome for the patients. So this is how we are collecting the tears, putting the extraction buffer, putting it into a point of care diagnostic kit, which is based on an ELISA multiplex system, and analyzing the test results. So the test results, like any other lab reports, we get it against a normative range, and that gives us what the patient is actually suffering from. So each marker, as we can see, like in here, IL-6, IL-8, MMP9, each have their own symptomology in the patient. So knowing the marker will help us in a targeted treatment. So this is the customized approach like we have developed. And in the future, we hope to see it in the clinics. Thank you.
Excellent talk, Dr. Ritika. I think it was very, very practical, you know, a lot of good way to document it and really understand and then treat DED. Dry eye disease today becomes the major, OPD attendee, today. So great. Thank you so much. I call upon Dr. Pooja Kamar now. She is a consultant cataract refractive surgery and clinical translational scientist at GROW and IBMS lab from Narayan Nethralaya, Bangalore. She is a fellow in cataract cornea refractive from the same institute. And I would want to talk about the fact that she's a PhD, and very few of us colleagues here are so acclaimed. And she is the one who's a PhD in wound healing and refractive surgery from the university in Netherlands. I welcome you, Pooja. And when you talk about collagen imaging, it's a beautiful topic because it's all about the ECM, the extracellular matrix, which forms the outer coat, and its balance of its lost structure or its less synthesis causes scarring. Let's hear you out, Pooja.
Thank you, ma'am. Thank you for the wonderful introduction. I would like to thank Mohita ma'am, WAS team, and the AIOS team for giving us this opportunity to present our work here. So I'll just go to the topic. We all know as refractive surgeons or as cataract surgeons also, there are a lot of indices nowadays like topography-based indices, biomechanical-based indices, and OCT-based indices. And this clearly tells us that we will be able to differentiate between the normal and the suspect keratoconic eyes, which will prevent us from having any gross complications from surgery. However, let's see these two patients. This is absolutely normal topography. normal indices. This is a suspicious topography, suspicious indices. This was around 7 years back, so we didn't know like this, the biomechanics were retrospective, and we had gone ahead and done a PRK surgery for them. To our surprise, the patient with all the normal indices landed up developing an ectasia. And patient with suspicious indices and a suspicious topography is still after 7 years doing normal with a very well-centered ablation, which we like, which is very pleasure to see to the eye. So, and we like as refractive surgeons, we come across our practice, which has around 25% of these patients. Also, the second case scenario is, if you see, this is also a normal topography, like a little bit on the steeper side, but normal topography. And like this patient was just kept on observation and asked to wear glasses. Suddenly, after 1 year, he came ahead and came back and said that, I have blurring of vision. We just repeated a topography because there was increase in cylinder power. And just see this, this patient has around 11 to 13 diopters of progression in just 1 year. So what are we missing here? Yes, we are looking, it's like a 6 blind men and an elephant. We look at just the topography or biomechanics, or we combine both of it, or we combine any two of it, but we are not looking at a larger picture. So what is the real truth? The cornea has, like, it's 70% is formed of the stroma, and stroma consists of the collagen fibers in this. And this collagen fibers provides the biomechanical strength, and it maintains basically the shape of the cornea. So it's necessary for us to imagine with this collagen. But how do we do it? Like, is there a way to do it, a non-invasive method to do it? But because whatever we have right now is invasive. So we developed a polarization sensitive OCT in collaboration with University of Vienna. It's just a polarized light which is thrown on your cornea. All the structures of the cornea, epithelium, endothelium, and Descemet's membrane take up this polarized light, but the stroma doesn't take up the polarized light. It's based on the principle of bifringence. So we utilize this principle, and then we go ahead and see how the collagen orientation in the stroma is. So this is how a theoretical, this is how the PS OCT looks like right now, but in future it will look like one of our OCTs. This is how your collagen orientation is in an arrangement is in the cornea theoretically for the right and left eye, and this is what you see exactly these are the polarization sensitive OCT images. Just to simplify it, like the darker the blue you see, it means like the better the collagen orientation and arrangement is, and the more it turns towards the yellow and red, just like our topographies, it means that it is a weaker arrangement and orientation. So this is how the normal pictures look like. So now let's see these two case examples: badly suspicious, TBI suspicious. Here all indices are normal, topography is normal. We did a polarization sensitive OCT. These are similar to examples which I showed in the beginning, patient who had developed ectasia. So if you see here, patient has suspicious indices, but the polarization sensitive has a normal orientation and arrangement of collagen. It's absolutely fine. But here the indices which were absolutely normal does have a complete loss of orientation and arrangement of collagen. So what am I seeing here? If I go ahead and if I would have operated this patient, like, I would have had a favorable outcome for this patient and an unfavorable outcome for this patient. So just to, this is what the power of collagen and polarization sensitive OCT is, and which will be in future in our near clinics for all of us. But just wanted to see if this is a true picture. We just, we do a lot of molecular based work. So we take the epithelium when we do a trans PRK, or we collect the lenticule and preserve it in our biorepository. And we do molecular analysis to study the extracellular matrix markers to see what is happening, which is kind of an invasive procedure. But it's very important for us to link whether what collagen orientation and arrangement we are seeing is same in our molecular markers. So similar to examples, normal indices, abnormal indices, we did a trans PRK and we collected the epithelium. This has a normal PSOCT and this has an abnormal PSOCT. And LOX collagen is just the it holds your cornea into place. If you see the normal collagen has PSOCT has a normal level of collagen here and a normal level of lysyl oxidase, which holds the collagen in place. But the place where like the PSOCT where it shows that there is loss of collagen, you can see that even the collagen is on the lower side. So this technically tells us that what we are seeing in PSOCT matches with your molecular data, which is basically on your eye. So in future, we don't need to do this for all the patients. If you have a PSOCT in our clinic, it will definitely solve the purpose. So it doesn't only have refractive surgery applications, it has applications beyond refractive surgery and KC and cross-linking outcomes. It can be used in diagnosing retinal disorders, post-graft imaging in your cornea. It is just like your GDX, but it's like a little bit superior version of GDX. So it will also help you detect the early changes in the nerve. And we are building the indices just like our topographer so that it's easier for us to read. And soon it will be collaborated with one of the companies and it will be in our hands. Thank you. I would again thank WAS for this opportunity. Thank you.
Thank you. Thank you so much, Pooja. And it's always so enlightening to see the kind of the clinical and translational research work that you do at Narayana Nethralaya. And this was so really enlightening. Next, I would call upon Dr. Swati, and she needs no introduction. And she is the first woman corneal surgeon in Rajasthan to perform maximum number of keratoplasties and helping eliminating the corneal blindness in Rajasthan. I'll congratulate Dr. Swati for that. And she is the medical director of Eye Bank Association in Rajasthan and also heading the Swanetra Eye Hospital in Jaipur. Over to you, ma'am.
Thank you so much, Maya, for this. It's a very humbling experience also. And I'm really thankful to WAS and Dr. Mohita to have me here. I would basically, I was given some other topic, but I thought of talking about this because I feel that definitely each one of us as a surgeon has a very important learning curve. And I also being, luckily into cornea and anterior segment, and I feel cornea is the most forgiving organ of all the organs of the body. And whatever you might do, you just end up with a beautiful cornea if everything goes on not so bad. So there are certain surgical videos that I'm going to show in DSEC. When I was learning DSEC, I had faced lots of problems, and because I was not in an institutional setup and I was in a private practice. So here I didn't have any cover or anything, but here you see a poorly vitrectomized eye, and I had put this graft, and the graft was very irregular, thin than the rest other grafts, and you could easily see that there is because of the floppy iris, it kept on touching at the back of the graft, and here a bubble was stuck in the center. And in spite of seeing all the videos and watching all the surgeries of surgeons who are doing cornea, when you are stuck, you innovate and think out of the box, and you try and do things which people have not done, and you could land up with a lot of problems even. But you tend to innovate a lot of things during the process of learning. There's a second video here. As you can see that when I started with, we were not doing automation, and this was the manual cuts that we used to do. And in spite of checking the whole graft, while doing so, I realized that my cornea was getting as bad as it could have been. And it was such a task to insert the graft inside the anterior chamber, and then forming the anterior chamber was again very difficult. And these are a few of my toughest cases that I had come across. The number is many, because the learning curve was, I don't know about other surgeons, but being an average surgeon, the learning curve was pretty high and steep. And I kept on struggling to put the graft, and we did see that the haze was clearing a little at the periphery, and I could actually visualize some part, but the bubble was not forming, and I had a tough time forming the bubble, and I was really worried about anterior synecdoche being formed, but later on got away with it. Again, there's another video which shows that I usually use a needle to insert the graft, and I made the dissection so thin. DMEC was not there in place at that time, but I think I kind of inadvertently did a very thin graft and inserted with a needle, and this is how my needle got stuck, and the graft was absolutely, in rolls. And later on, to to de-roll the graft was such a difficult task. But a lot of times when you are going through all this and you have not an institutional support, that is what you land up with. So these are a couple of my cases that I would just show the pictures of having a very bad detachment on day one. And as I said, the cornea is so forgiving that I think we humans should learn from that. And this is after rare injection on day 7. Another case on day 7, the cornea looked pretty bad, and my patient was not very happy because he thought that the DSEC is going to do wonders. That is what they searched from Google. And after 3 months, the cornea started clearing, but post 1 year, definitely the cornea cleared a lot. So when you start with a bad cornea and then when you do a good graft, it is okay. But when you land up with a lot of complications like a DSEC detachment or even a smaller detachment, as you can see in the lower right corner, this causes a lot of problem, and it keeps the patient symptomatic. This was one of the phakic eyes with vitreous touch syndrome, which you can see that on post of day 1, very irregular dissected cornea. I think I did a very bad job in dissecting a cornea like this, but then gradually when I filled with air injection, the edge always kept on detaching on all the serial OCTs that I did, and I literally had a problem in that area. But then, as I said, the cornea does clear, and we need to have practice patience. A lot of times we just get away with it. There's another another case in which there was a double DM. I did not remove the DM completely and put a graft there, so there are 2 DMs in one. So like this was such a surprise to me when I did an OCT and I thought that the DM was fully removed, and another one, and I did such a small graft that there was a huge gap that I left. So these are the series of cases, and I had these eccentric grafts, the poor manual dissection ranging from pupillary brock to resolved after dilatation. So the list is never ending. So I would always say that when you are doing such kind of surgeries, you'd be very, very grateful, and you should always thank your stars if you get away with it. And the learning curve definitely varies from surgeon to surgeon. Maybe some surgeons who are doing really good. And with this, I just want to share this rare eye disease issue that is coming up in IGO from BOSS and IGO and AIOS, and the submission deadline is 15th of July. So I welcome everybody to please come and submit these your rare eye disease articles in the special issue. And thank you for giving me a chance. Thank you.
Thank you so much, ma'am, for sharing your learning curve and sharing your series of cases. I'm sure it would help a lot for the budding corneal surgeons. We have another corneal surgeon with us, Dr. Sujata ma'am, and she is the Associate Medical Director at Rajan Eye Care in Chennai, and she is also the head of the Rotary Rajan Eye Bank over there. And I must mention that she is a recipient of a very coveted Nari Shakti Puraskar recently for her philanthropic work for eliminating the corneal blindness. We look forward to hear from you, ma'am.
Thank you, everybody. At the outset, I'd like to thank WAS, Mohita Sharma, and the scientific committee for giving me this opportunity. I'm just going to show you 3 videos because I've been given only 6 minutes of DALC and challenging situations. These situations are achieving the big bubble, how to do a manual dissection, and managing a perforation to convert or to proceed. So my go-to in getting a big bubble is using a 30 gauge needle and injecting it deep into the stroma and forming a big bubble. Once you get a big bubble, then it becomes very easy. The whole procedure becomes very easy. Then you just need to do a dissection of the stroma above the decimates, very carefully at all times, making sure that the eye is soft by decompressing the anterior chamber. And these bubbles usually form, you get very nice bubbles with keratoconus patients, anterior dystrophy patients, but some macular dystrophy, it's very difficult to get. So you can see that once you've got the decimates exposed, then you can go ahead with removing the endothelium from the donor graft. And normally I prefer to use the same size donor and complete the surgery, particularly in DALC. This is again a patient with keratoconus with an excellent big bubble. This is actually my first case done in 2004. So this is how the whole thing goes, and the graft is sutured with interrupted sutures, and the procedure is complete. So coming to the next case where I had a problem. Let's see, I got a very nice bubble first. You see, this is a patient with macular dystrophy, and I really had a doubt whether I'll be able to get a bubble. I did a superficial keratectomy. So I injected air, but it went into the anterior chamber, it decompressed, and again gave an injection, got a type 2 bubble, which is smaller, and I re-roofed the bubble. But unfortunately, in my enthusiasm, I did it again. That is a big mistake. And I touched the DM, and you can see some aqueous coming out. So actually, I had punctured the bubble. And now my problem was that what am I, now all the air is lost. I was not able to find the plane. And so the question is, so I decided to go ahead with the manual dissection. And you can see as I'm doing the manual dissection, the air from the anterior chamber keeps escaping. So the best thing would be to do a suturing. Just suture the air, suture the area of the defect, and continue with the dissection. Now I identify the bubble of the original bubble. So again, I de-roof the bubble. And once I got into that plane, then everything becomes easy. Now, when I injected viscoelastic, we can see that it is separating the Descemet's membrane from the superficial stroma. Then you can go and give multiple cuts using a blunt tip vannas and then expose the endothelium. So in this case, because the bubble was not complete, the periphery needed a little bit more dissection. So to make sure that completely the graft will be sitting properly. And the last thing to do is to remove the suture. And then you can go ahead with removing the endothelium from the donor and using a same size graft. Using a same size graft, particularly in perforation, helps because the chance of double AC is less. This is a pre and the post-operative picture. And you can see the area of perforation as well. A little bit of graft edema persisted for some time, and then by the end of 1 month, he was perfectly all right. So coming to the next case, this again a patient with a stromal dystrophy. Normally, I prefer to put a Fleringer ring on all my cases because in case I need to convert, because most of these patients are young patients, and I always put them under GA. And just to make it quick, you can see that I was not able to achieve the bubble. So I started doing a manual dissection. And there was quite a lot of scarring in this in the dystrophy. So it was quite difficult to do the manual dissection. But nevertheless, I thought it's better to have a DALC, even if it's a partial near total DALC, than to go in for a full thickness. See, you can see again one more perforation. So I injected air. The perforation was quite large and I was not able to continue with the procedure. So I sutured it. So, in suturing, once you suture, then the air stays behind and then you are able to remove the rest of the stroma. That's a great advantage. And then once you remove the stroma as much as possible, you can go ahead and suture the graft, which has been prepared already. So this is the post-op. You can see the suture in the interface, and the graft is quite clear for the first post-op day. So this is again a patient who had a graft perforation. You can see the post-op, you can see the area of perforation, but these grafts really clear up. And I do an inferior PI in these patients so that I can have a complete airfill. So that prevents an anterior chamber collapsing. This is the last case which I'm going to show you. It's an unresolved hydrops. Patient was having hydrops for more than 15 days. So I gave an air injection, which didn't suffice. So took her up for a venting incisions, followed by an injection of non-expansile C3F8. And because the C3F8 remains in the anterior chamber for a longer time, usually this works very well. In most of my patients, they have really responded well to this. But in the first day post-op, there was some clarity, but you can see that now the whole thing has opened up and it was like an impending perforation. And the graft edema actually had increased much more, as you see in the ASOCT. So I gave air injection just to facilitate my dissection, manual dissection. So, I mean, it's not a conventional method to do during an active eye drops to do a DALC. But in this case, the patient was already 1 month into this eye drops, not responding because of the size of the eye drops. And there was a potential for impending perforation. So with the combination of 15 number blade and a crescent knife, I did the maximum dissection as possible and sutured the graft. So this patient actually did pretty well, and post-operatively, she had actually a high myopia as well. So in addition to her myopia, so you can see the area of perforation, this central area was perforated, and you can see the irregular thickness of the stroma in the first week, but over a period of time, it became extremely thin once endothelium started working, and she did very well. So some of the postoperative complications are AAC, Descemet's membrane folds, particularly in keratoconus, delayed epithelialization, stromal melt, infections, interface haze, high astigmatism. So this is a patient with a AAC. AAC, the best thing would be to give an air injection and position the patient. Otherwise, if it's a recurrent, then you go for a C3F8 or SF6 gas. Or in a persistent AAC, I've even changed a graft to a smaller size graft. So again, another problem with DALC is delayed epithelial healing, as you can see, because of graft host disparity. Thinner corneas, when they keep a thick donor.
Sorry, doctor, to interrupt in between, but the time is now over, and I request you to please wrap up in the next 30 seconds.
So this is persistent epithelial defect. So DM folds, high astigmatism, or some of the complications associated with DALC. So it has a long learning curve, and it's important that you practice on eyes and go to wet labs to get the best results. Thank you once again for the wonderful opportunity.
That was a wonderful talk, ma'am. And I think you very well tackled all the surgeries you took up and the way you innovated the ones which couldn't have a bubble. Heroic surgeries, ma'am. I'll call upon Dr. Sheetal Mahuwakar. She is a senior consultant cataract cornea refractive surgeon at the Retina Foundation, Ahmedabad. She specializes in cornea, cataract, refractive, with special interest in complex cataract surgery, secondary IOLs, complex ocular surface surgeries. She is going to talk on ocular surface review. When I see ocular surface anywhere, I always feel this is the most important structure. It is the 86% which falls under the meibomian diseases. And it's all about hyperosmolarity, which is going to lead to apoptosis and to lead to a reduced mucin. So it's all a lot to hear on DED. Let's hear you, Dr. Sheetal, to make us crack such diseases. Go ahead.
Thank you. Thank you so much, Dr. Aarti. At the outset, am I audible?
Yeah, yes.
Yeah. At the outset, I would like to thank Dr. Mohita and the entire WAS team for giving me this opportunity. Ocular surface has, I think a lot of my friends know that a topic very, very close to my heart. So what do we mean by ocular surface is basically it is conjunctiva cornea and a healthy limbus with healthy limbal stem cells. Now what it does is with the healthy limbal stem cells and the tear film, it maintains the equilibrium of the ocular surface and it helps us to provide the clear vision. Whenever this gets disturbed, we have this plethora of ocular surface disorders which can happen, like a severe dry eye and primary or secondary Sjogren's syndrome. Chemical injuries, acute as well as chronic, which can cause a picture like this, where there could be a lot of symblepharons or granuloma formations. Limbal stem cell deficiencies, there could be a lot of reasons like VKCs, like your post-chemical injuries or any kind of systemic conditions. The most deadly disease for me is the ocular cicatricial pemphigoid, because it sometimes if not treated early with severe immunosuppression, aggressive immunosuppression, it can lead to blindness very fast. And last but not the least, something like Stevens-Johnson syndrome, where you get a lot of dryness, symblepharon, and keratinization of the ocular surface, which could lead to something like a bone dry surface at the end stage. So what I'll be doing is I'll be sharing few of my cases. So this is a case of a child with SJS syndrome who came with pain and foreign body sensation. As you can see, the whole lid margin is keratinized. Now this is a mucocutaneous junction which gets affected in SJS, and the dermal epithelium starts coming over this non-keratinized epithelium of the tarsal conjunctiva. What happens is whenever we blink, this is the area, the mucocutaneous area comes in contact with the ocular surface and it starts breaking your ocular surface and starts affecting it. So when we see these cases early in the stages at something like this, where there are just small erosions in superiorly and inferiorly, this is the right time to do a lid mucous membrane graft, where we obtain a biopsy from lip mucosa or a buccal mucosa. Many a times what we have seen is if we do these cases at an early stage, we see the reversal of the corneal changes, including the vascularization. This is a case, again, a very close, a case very close to my heart, a 26-year-old male, systemic condition, although we could not diagnose anything, but he had a lot of rashes on the whole body, and he had bilateral limbal stem cell deficiency. I avoided this patient for a year or so because he came early in my surface journey, actually. And after a year or so, I decided to go ahead with alloslate. There are only two choices when there is a bilateral limbal stem cell deficiency. Either we can do keratoprosthesis or we can do simple limbal epithelial transplant. Now, because both the eyes are involved, we have to do allo. So we took the limbal biopsy from a father, and we did the slit. So this is a case where you can see how his epithelium is improving. And now I have a long follow-up, in fact, for this patient, more than 4 years or so. And he's maintaining vision pretty well. He's maintaining ocular surface pretty well. And he is on immunosuppression, systemic immunosuppression. This is another case of bilateral limbal stem cell deficiency where we went and did the keratoprosthesis. In keratoprosthesis, BCL is very important to maintain the carrier graft, carrier corneal graft, to maintain its integrity. So sometimes we have to do the modifications, like in this case, we did a keratoprosthesis, but the BCL could not be placed. So we put the amniotic membrane and did the medial and lateral tarsorrhaphy. This is a case, again, now Ocular Surface 2021, the topic was there. So I just thought that let me share my latest case, which I did it after the first wave during the lockdown has come off. We did the keratoprosthesis because, again, this patient had a lot of symblepharon. We did this keratoprosthesis under pannus, under the conjunctival pannus. So now keratoprosthesis is a procedure. It's like greater the climb, bigger the fall kind of a thing, because this gives a lot of vision, or maybe it's a life-changing thing for a patient who is bilaterally blind, but it has its own complications. You need to follow them up very, very closely. You need to keep on intervening in between. And this is a patient, after initial few follow-ups, we again came up with the second wave and we could not follow up. So this patient now every 10 days sends me this video that and tells me about, you know, his symptoms, his vision, or any other complaint if he has it, and we are following him up like this on this thing. In fact, the photo on this, on the left side, which you see, is he sent it to me today morning. So this is what I say, that this is something which we all need to learn, that how to kind of, you know, solve these problems, where we need to follow up these cases very, very regularly. Otherwise we can again lose them, and it can cause a lot of bigger problems. Thank you so much.
And thank you so much, Dr. Sheetal. And these are really challenging cases, and you have shown us so beautiful results, which are so rewarding. I congratulate you for that. So next we have Dr. Nilima Mehrotra for her talk. She is the head of the ophthalmology department at SRMS Medical College, Bareilly, and also the head of the eye bank over there. And I think ma'am is also heading the UP chapter of the WAS. Over to you, ma'am, for your talk. She'll be speaking on the IOL, choosing the right IOL. You can start sharing your screen.
Thank you, Dr. Maya, and I will be sharing my screen now. Is it visible, and am I audible?
Yes, yes, ma'am, go ahead.
Right. All right, good afternoon, and I'm really enjoying this WAS session here. Thanks a lot to all of WAS and Dr. Mohita and AIOC for having me here. And the topic I'm going to talk on today is choosing the right IOL, which will win you your patient over for life. This is one of the things we all are commonly doing in our routine practice. So I picked up this line, which really makes sense to us, is if we consider surgical technique and our surgical skill as the art which ensures that cataract procedures go smoothly and give us great visual results, then IOLs are the science. So when we are talking about what IOLs to choose, these are few of the things which we must talk about to our patients, because the price is a consideration, reading glasses, whether the patient is happy to use or not, astigmatism, Again, toric lenses, the desire of patient to be spectacle free, the patient's visual needs, the condition of the other eye, other ocular pathologies, any previous surgeries, and any lack of zonular or capsular support during or before surgery, and whatever occupational requirements or patient's desires for vision aid. So this is the Ridley lens at the top for you. So the question today is, should we be traditional cataract surgeons or should we be refractive cataract surgeons? If we are not refractive cataract surgeons, it might be just that we do not want to, but otherwise in the market, we have so many premium lenses and so many options for post-op refractive procedures. So why we go in for all these lenses is because we want our patients to be more and more satisfied with the post-operative visual results. Why we don't use these lenses is also because we know our patients get really dissatisfied, which may be because of over expectations at some times, or maybe because of uncorrected visual acuity not being 6x6 or 20x20. So we must not only think of the most premium lenses to use, but also think of enhancing post-operative visual acuity, because that is what drives patient satisfaction. Because what our patients want is everything. One of the studies by Scalhorn showed that patients after LASIK who had vision of 20/25, about 20%, 1/5 of the patients were not happy. So we need to target 20/20 vision. Post-op laser tuning or piggyback lenses. It may be intimidating thought for us to tell our patients to go in for another surgery, and we might be too busy cataract surgeons to do it, but this is what we should think. If we do not want to, there is still something at the horizon, that is the lenses which can be customized to patients' desires, patients' vision, and these are the light adjustable IOLs, which would be there for us. Pre-op measurements may not equate to post-op outcomes. This is because of finally how the implant wants to rest, and because of how the astigmatism shapes up because of healing. So these light adjustable lenses, after 3 weeks of post-op, we can laser change their power to suit what the patient wants. So these are the truly customized lenses, and they're almost there in the market for us. So do we have a lens which is advanced enough to be called premium? Probably or probably not. So what you choose is from a wide range. We have a wide range because we don't have the best one yet. What do surgeons, according to 1 or 2 surveys which I was looking up, how do they rank the premium features they want in a lens? Asphericity, which is there in all our monofocal lenses also, and toric design are the top things which they want, because they want to target the astigmatism, which is so disturbing to vision afterwards. Monofocal lenses are still our bread and butter. Most of surgeons, for most of their patients, want to do the monofocal lenses because of the ease of their use, ease of insertion. There are preloaded ones, slow unfolding. You can position them perfectly. There is consistency of results. You can sleep happily. There is reliable outcomes. Glistenings, reflections, any of the dysphotopsias are not there. And these lenses are really versatile. You can put them in the sulcus, God forbid. So these are some of the lenses which we are all commonly using. So we can now alleviate astigmatism, the surgically induced astigmatism, as well as the pre-existing astigmatism with our toric lenses. They are very, very stable, and the refractive predictability is high. They are easy to implant and rotate. However, sometimes some issues some surgeons do have with the translucent markings, and they may be best used with the is the 6 minutes up already?
Yes, ma'am. The time is up.
I'll just take 1 more minute because we have a love-hate relationship with our presbyopic lenses. One of the things with the presbyopic lenses is the diamond eye light reflexes. I don't know how much you have experienced, but a lot of our patients, families come back to us and say that they don't like the sparkling of the eyes of their family members who have undergone these surgeries.
Okay.
Extended depth of focus lenses, they give us a good range of vision. And these are the lenses also a lot of our patients are more happy with, and the surgeons are happy also. But if you want the wow response, maybe you might want to go in for accommodative lenses. Monovision is what we have been practicing since long with our monofocal lenses, is still doing well. And a lot of our senior surgeons do swear by it, and they want to go in with a precise monovision. What is best to do is the dominant eye, make it plano for distance, and the other eye slightly myopic. You may mix and match lenses. You may use extended depth of focus in one and a multifocal in the other for the near vision as well as. Don't forget unpleasant financial surprises, because the cost factor is what you must discuss with your patient. Also, don't forget that sometimes, even though rarely, you might have to explant lenses or suture them because of perioperative conditions, or explant or in exchange lenses, which is very unpleasant indeed. Thank you so much. This is something I really liked, so I put it up for the last slide. Thank you.
Thank you so much, ma'am, for that comprehensive overview of different types of IOLs. And next in line, we again have a very prolific, complex cataract surgeon with us, Dr. Vaishali. She needs no introduction. She is the director of Raghuti Pai Hospital in Jaipur, and I'd invite her for her talk on complex cataract surgeries. Very popular pediatric cataract surgeon as well globally. Over to you, Dr. Vaishali.
Thank you so much, Maya, and thank you, Mohita ma'am, Aarti ma'am, and everybody in the AIOC Scientific Committee. I will not take too much time. So I'll be showing this case. It's not terribly complex like the cases we saw in the beginning, but this is a 16-year-old boy with an injury, and we see that there are multiple issues. The pupil is torn and ragged, and there is a white cataract, and there is a tear in the capsule. So what we do first, what I wanted to show is that always start with a small incision until you reach the stage where you need a large incision for an IOL, particularly in these young guys. Having stained the capsule with trypan blue, these are all fibrotic capsules. Most of the trauma cases, you will have some degree of fibrosis. So a combination of micro incision scissors and forceps is very useful, and therefore I like to make at least 2 side ports here and 1 here, so 3 side ports, so that both hands can be used. And I'm trying to make a rhexis using a combination of cutting and pulling as much as is possible. Now here the iris is completely chafed and traumatized, so we need to be careful in coating it with a dispersive viscoelastic so that you don't make it prolapse and cause more injury. Because it's a soft cataract, you don't need phaco. Bimanual IA here works, in my hands at least, it works better than coaxial IA because I can maintain a closed chamber and I can access 360 degrees. And I'm trying to work with as low a bottle height as possible with reasonable vacuum, because we don't know what can happen in the posterior capsule. It may be ruptured, it may be intact. Plus the iris tissue, as we can see, is a little fragile. So take your time and then remove all the cortex. Every time you switch hands, as you can see here, there's a trickle of hyphema from this traumatized iris. So for maintaining the chamber and for tamponading this hyphema, I've injected a dispersive viscoelastic and I've swapped my hands. And you can see here a sort of a partial rhexis. So here there is a tear, the rest of it has been converted to a capsulotomy cum rhexis. And the lens was removed, the posterior capsule is intact. The question now would come is that as such it was the end of the case. I could have just put in a lens in the bag and the case gets over. But as we can see here now more clearly that there is no continuous rhexis. So this lens is bound to be tilted and come up and cause capture, synecdoche and asymmetry, which can further aggravate all the inflammation. So what I have a lot of surgeons that are both our centers, we have started doing now is performing a posterior capsulorhexis in these traumatic cases where there is an anterior capsule rupture. So we electively start a rhexis under the cover of a heavy sodium hyaluronate, and again using bimanual instrumentation and micro forceps, slowly we try and make a capsulorhexis of about 4.5 millimeter diameter. With the idea of capturing, that means putting the 3-piece lens in the capsular bag and then the optic is made to slide behind the entire posterior capsular axis so that it remains fixated and cannot cause any tilt or synechia. I do agree that it is not easy, and in every case I may not be able to achieve the size I want to, in which case I'll just put it in the bag. Anyway, I was going to put it in the bag. Now injecting triamcinolone acetonide, again to make sure there is no vitreous, and then filling the capsular bag. Make sure that you make space between the anterior and posterior capsular axis. So like I said, the safer and easier option would be just to put in a lens in the bag. But then you are endangering the eye not only with unstable IOL, but a lot of inflammation and glaucoma complications in the future. If I could not have done this PCCC, I may have left him aphakic or have done any of the sutured or non-sutured scleral fixation options. So what my first choice here is to try and put a 3-piece lens, and this animation shows why. Because you have captured the lens through the posterior axis, it is hopefully going to remain stable because it's a young child. Now I prefer to do a manual implantation. You could use a cartridge, and obviously the incision needs to be enlarged to 3.2 or more at this point. Anyway, the eye is going to be sutured, so I don't think the size of the incision is too much of an ego issue here. This technique only works with any kind of a 3-piece foldable IOL or even a single piece PMMA IOL. But for that, you would obviously need a much larger incision. Now, because it's a young boy, because the pupil is so traumatized, I'm using the single pass 4th row pupilloplasty technique and trying to create some semblance of a round pupil. It's not perfect, but at least in this quadrant where there's complete loss and tattering of the iris, this would also prevent synechia or peripheral anterior synechia in the future. And the incision, although it's only 3.3 millimeter, has been sutured because, again, young boy trauma, we don't want any kind of instability. And this is what the child looked like post-operatively, not the ideal scenario what you wanted, but at least you have a good quiet eye and a stable IOL and a decent pupil. So I think that's from my side.
Yeah, I think that was a perfect timing, Vaishali, and a perfect stepwise approach to a very difficult case. And the end result was absolutely wonderful and very good.
Thank you, ma'am.
Vision for the boy makes his life a better one for the rest of his life. Now I invite the doyen of smiles, because she has the prettiest smile. She's the refractive surgeon since 1994. So I think the longest tenure surgeon, first person in the world to do one incision smile, pioneer and an early investigator who helped develop the technique of smile. First in the world to use circle software in a patient for retreatment in smile. Trained more than 1,700 ophthalmologists across the world. One of them is me also, so I'm very privileged. I call upon the smiling lady, Dr. Rupal Shah, to talk all about her journey of smiles. Welcome you, ma'am.
Thank you, Aarti. That really put a smile on my face. Am I audible?
Yes.
And my slides are visible?
Yes.
Yeah. Thank you so much for inviting me for this wonderful session. And congratulations for the organizers of WOS, that you guys are doing a wonderful job. I'm a consultant to Carl Zeiss Meditech. I'm going to be describing my journey of smile. And I hope that it is going to be inspirational for others, because at the end, I will just give you a take-home message. So basically, I got this opportunity to study this particular procedure right in the beginning. There were only 250 eyes done in the world by Professor Walter Secundo and Marcus Blum from Germany. And they started their clinical studies in 2006 and published their initial results. And after that, they had shown that the procedure was feasible, was accurate, but the vision recovery was too slow. And at the Center for Sight and VLC, we started these studies in August 2008. At that time, I was running the New Vision Laser Centers. It was a non-corporate. I was in private practice. And this came like a big opportunity. I was doing only refractive surgery for years together. And looking at the procedure, I thought that there was an intuition that it looked like a procedure that can have a great future. So with great enthusiasm, we took this opportunity. And we were very surprised initially with the initial few eyes also. about the accuracy of the results. And these were the first few eyes done in the world with no nomogram adjustment. And yet the refractive error correction would be right to the dot. At 1 year, we found that more than 95% of our eyes were within plus or minus 0.5 diopters, which was even more encouraging. I was also surprised by the surgical ease. Believe me, I had not seen a single procedure getting done before I did my first flex, because they could not just arrange any procedures to be seen in Germany. We waited for a month. And then I said that just show me a video and let me just start. And we started. And I could actually do it. And I found that there was no corneal edema, not much corneal edema, no haze. Of course, since no one had performed single incision smile before, I also needed to design some instrument to facilitate it. And the thing that was bothering us all the most was the long vision recovery period. This is the first flex procedure, but I don't, for the want of time, I'm not going to touch upon it. In the initial study, we first started with flex. Flex was not like the modern day smile. Here, we would make 2 passes of the femtosecond laser, but the second pass ended up in a flap. So we had a whole cut. So you can open a flap, peel out the lenticle from the base, and then put the flap back. This was like a stepping stone, but within our first few eyes only, I quickly moved on to pseudo smile, because I knew that there was not really much advantage to doing it in the flex form. And we published our results of the first 50 smile eyes in the Journal of Cataract and Refractive Surgery in January 2010, which was the first publication of smile with a single incision as the way it is getting done today. Obviously, the slow vision recovery was a matter of great concern, especially since the origin of the slow recovery was simply not understood. It always used to baffle us. And therefore, several alternative explanations and theories were constructed, and we conducted several interventions to rule out these theories. So one theory was that we thought that maybe there is excessive inflammation because you are doing 2 passes of the laser. So we started putting a drop of steroid in one of the eyes in the interface. In the contralateral eye, we didn't put, but it didn't work. We tried putting a bandage contact lens in one eye and not in the other, and next day the recovery would be the same in both eyes. And we also tried doing a PTK on the undersurface of the flap and the remaining corneal surface to rule out surface roughness, but none of these interventions gave a good result. So the insight into visual recovery came from the observation that in certain patients, we could actually make out that next day this patient will do well. And so we went back and looked at those, and we found that wherever there was a smooth, no bubble formation in the center while the procedure was getting done, we were getting good results. And this is the explanation, that the first pass would go through and make a nice cut, but the bubbles will soon coalesce, and then the second pass would go through this irregular surface. So when you remove the lenticle, you are left with an anterior surface which is irregular, and the epithelium comes to the rescue and just heals over a period of time this irregularity. So we suggested to change the scanning pattern. This was the original scanning pattern, where we used to go from center to the periphery for posterior pass and followed by the side cut of the lenticle. I'll just take half a minute. And the second pass would come from periphery to the center. And you can see by the time the second pass is reaching the center, there is a lot of bubble accumulation in the center, and it's causing it to be very, very irregular. So you can imagine when you remove that lenticle, you're going to have a vision recovery which is not so good. So we suggested simply a change in the pattern of scanning, which is the way it is getting done now. And Zeiss complied, and we then went on to doing it this way, where we did the first pass in the posterior plane from periphery to center. And you can see now the center is not showing so much accumulation of bubble. When the second pass is going through it, the bubbles come up later, and therefore they would not have much vision impact on the vision. And you can see this eureka moment. While we had only 65% unchanged or gained vision at 1 week and 94% slowly creeping at 6 months to unchanged or gained, simply changing the pattern of scanning gave us 83% unchanged or gain at 1 week and 98% unchanged or gain at 6 months. So you can see the difference, and that gave all the understanding for the future improvements. And this happened then very quickly. So we could increase the frequency from 200 to 500 kilohertz. Then they were increasing the spot spacing. Every effort was made to make sure that there were no bubble accumulation in the center before the second pass would form. And this led to a more precise and an absolutely state-of-the-art procedure, which is how it is getting performed today. The current focus for improvement today is just coming to an end. I'm focusing right now on increased surgical ease. Ultimate idea is to have a free floating lenticule, and so I'm trying to play with the frequency, spot spacing, and lenticule thickness. The remarkable aspects are that it's been remaining the same since so many years. The predictability, safety. More than 3 million procedures have been done. As a take-home message, I just want to add one thing, that if there is opportunity thrown towards you, please grab it with both your hands and give in your best, all in terms of all the experiences that you have, and apply yourself, and you can actually succeed. Thank you so much, and I'm sorry to exceed my time.
Thank you, ma'am, for sharing your experience and those practical tips regarding SMILE. So next we have Dr. Silky Singla, a very dynamic young WAS member, and she'll be speaking upon the supracore. Dr. Silky, you can start sharing your screen. She is a fellow at Tirupati Eye Care Center.
I hope it is visible, ma'am.
Yes, please go ahead.
Thank you for the opportunity, ma'am. I'll be speaking today this evening on the supracore planning and outcome. I'll not take much time. Starting with the supracore, we will be discussing about the TNEO, Bausch & Lomb company, no financial interest. It is based on the central near vision correction, that means creating a central 3 mm bump in the center, while a 3 to 6 millimeter distance zone with a smooth intermediate zone, having no glare and halos. As I said, it's a central steepening of up to -2 diopters with the outer region of flattening. A detailed anamnesis of the patient is required based on the patient's lifestyle, refraction, complete eye examination. Out of all, the most important is a detailed evaluation about the post-supracore vision. It is based on the simulation test for the decreased distance vision, in which we can have plus 0.5 diopter spherical, adding on to the best corrected visual acuity bilaterally to simulate the potential blur. While to assess the near vision, we can add plus 1.25 diopter spherical lens on bilateral addition, or if we are planning the monolateral treatment, we can add plus 1.5 diopter of spherical in the non-dominant eye. Clinical evaluation, photopic pupil size is must, as it is based on the pupil dependent. In OBSCAN, it must be more than 2.9 millimeters, while it is more than 2.1 millimeter on OBSCAN 3. Ensuring the proper centration and angle kappa should be less than 10 degrees. And to be more precise, it should be less than 8 degrees. In hyperopic patients, we should start with the phase of bilateral treatment approach that is based on the non-dominant eye, correcting with the supracore regular. That means we are correcting up to 2 diopters of the near addition with a target sphere of -0.5 to -0.75 diopters. While in the dominant eye, we are using the mild supracore that is equivalent to correcting 1.5 diopters addition with a target sphere of E-metrope or plus 0.25 diopters. As I said, we will use a profile of mild and regular that is given over in the screen. In myopes, we can start with a monolateral treatment approach. That means correcting the dominant eye with a normal LASIK, having a E-metropic eye and a non-dominant eye with a regular supracore equivalent to 2 diopters correction of addition. So choosing the ideal patient will be the realistic expectations, no night vision, critical occupations, monovision tolerant, LASIK suitable should be the patient is, and the low astigmatism with the adequate pupil size.
Ma'am, I'm so sorry. The time is over actually, so it will be great if you can wrap up in the next 30 seconds.
Yes.
quickly coming over the outcome, we have evaluated 38 phakic patients and 12 pseudophakic eyes with a good independence from the reading glasses who can read mobiles, computers, and menu cards. As a myth, there is high order abrasions at the 1 month with a significant change, while the fact is the change is stabilized over the 3 months. Case 1, we have right eye soft supracore with the left eye regular supracore who underwent the surgery and with a binocular undercorrected visual acuity 6/6 part and N6. While case 2 was a happy patient. In case 3, we found a unhappy on the simulation test. So we did only LASIK in the right eye with no correction in the left eye. On subjective questionnaire based unaided reading acuity.
Sorry to interrupt. This talk was for 3 minutes actually, so you have to wrap up.
Wrap up. I think we got the take home that it has to be customized.
Yes,
Very
ma'am.
well
It
done.
has to be customized on the simulation, and it's a promising press by LASIK ablation profile.
Perfect. I think in a better time we'll hear you more.
Yes. Thank you for giving chance.
Great.
Thank you.
I call upon Dr. Sneha Sen Gupta. She is a fellow at the Narayan Nethralaya. I'm going to straight away go to her topic, getting the right sizes of ICL.
Is my screen visible, ma'am?
Yes.
Yes.
Good evening, everyone, and thank you for the opportunity. To start with my talk, we know that there are multiple options currently available to give to our patients for spectacle independence. But in those patients where cornea-based refractive procedures cannot be done, we can go ahead with lenticular-based procedures like refractive lens exchange. It results in loss of accommodation. So the best option is phakic IOL. Here are the indications and the contraindications for it. Indications include a myopia of -1 to -30, hyperopia of 0.5 to 15, cylindrical power of 1 to 10, more than 18 years of age, ACD of 2.8 and more, ametropia not suitable or appropriate for excimer laser correction, and RSB of less than 250 post-correction. Contraindications include progressive refractive error and reduced endothelial count, glaucoma, narrow angle, ACD less than 2.8, cataract, pseudoexfoliation, pregnancy, nursing, and individuals prone to injury. Phakic IOLs are also being used in certain special conditions like post-refractive surgery, if there is a residual power, management of stable keratoconus in post-crosslink patients, post-keratoplasty, pseudophakic eyes in pediatric anisometropy and presbyopia too. Now, evolution of phakic IOLs from angle supported to iris fixated and posterior chamber has decreased the complications, but currently the most encountered one is due to imperfect sizing. Here are the types of posterior chamber phakic IOLs. It includes the Star Surgical ICL, IPCL from Care Group, refractive implantable lens from Appaswamy, ICRIL phakic IOL from Biotech Vision. Now the workup includes vision refraction, slit lamp evaluation, a squint orthoptic evaluation, glaucoma evaluation, specular microscopy, optical biometry, corneal topography, white to white, UBM, anterior segment OCT and aberrometry are optional, and a dilated retinal examination. So this is a flow chart for an ideal workup. Now, the hurdles that we encounter in a perfect phakic IOL selection are which one to choose, the white to white, the scleral to scleral, or angle to angle, which values to be considered from which machine, and the available phakic IOL sizes. Now, the most important for phakic IOL calculation is the refraction, and accurate refraction is the foundation for a good ICL selection. And for the sizing is the white to white, which is most important for the ICL sizing. Now, why correct sizing is important is a larger IOL can result in a higher vault, anterior bulging, and pigment dispersion, endothelial damage, raised IOP, and angle closure. A smaller phakic ICL can result in lower vault, anterior lens touch, and cataract, and post-op rotation of ICL. Now, a vault is a distance between the posterior surface of the ICL and the anterior surface of the lens. The vault limit should be between 50 to 250. It should range from 250 to 700. Now, we can either use a white to white, or sulcus to sulcus, or angle to angle to measure the, to calculate the size of the phakic IOL. White to white can be from OBSCAN or manual measurements.
I'm so sorry. Thank you so much. The time's up, and we can call upon the next speaker now.
Sorry, Dr. Sneha, but now
no problem.
Yeah, the time is for 3 minutes for the rest of the talks. So I quickly invite Dr. Neha to please share her screen, and she'll be speaking on a very important WAS initiative, that is the Rare Eye Disease Registry. Dr. Neha, please, your talk of the time of the talk is 3 minutes.
Yeah.
Please be
Good evening. So I'll be talking about a very important and new initiative of WAS, which is the RED group or the Rare Eye Disease group. So I'll share a video which will basically give a background of what this Rare Eye Disease group is all about.
Just like no two zebras have the same stripes. Each of the rare and genetic eye disorders that we encounter in our clinic is different. Most of them currently lack a therapeutic management. Let us all come together and form the RED group dedicated to the rare eye diseases. The rare eye disorders vary across the country. It's time the clinicians from different parts of the country come together and help in forming a cloud-based national eye registry and contribute towards research for discovering newer therapeutics in the management of the rare eye diseases. The RED group shall work towards providing genetic testing and gene therapy, genetic counseling, visual rehabilitation, occupational therapy to the visually impaired, centers for low vision aid, support group for the visually challenged, and formation of a cloud-based national rare eye disease registry. Each disease is unique, so let us all make a difference.
So the rare diseases, they don't have any universal definition, and especially in developing countries like India, there is no standard definition. So there are some rare eye disease registries present across the world, which is in Europe, Africa, and America, but none exists in India right now. Hence the idea behind creation of the RED group to collaborate, research, and report unique disorders. So this is what the aim of the RED group is, to form a support group for rehabilitation, counseling, genetic therapy, and provision of low vision aids to the patients, and creation of a national registry. So how do we do this? So we had a sensitization meeting in October last year where we decided that
Neha, sorry to interrupt. I think we'll have to wrap it up because we are running short of time, really. Yeah, I'm so sorry. Yeah, the beautiful video. I congratulate you for that. Dr. Anuprita, can you please start sharing your screen? And now we'll have just 2 minutes for this talk as per the instructions from the chairpersons, because the next session is already running short of time. So please go ahead, Dr. Anuprita. It will be for 2 minutes. Dr. Sonal, can you start sharing your screen? I think Dr. Anuprita is not here. Dr. Sonal, that will be the last talk for this session. Dr. Sonal.
Yes.
Yeah. So Dr. Sonal is the assistant.
For rare case presentation. Yeah.
Yes.
Is my screen visible?
Yes, please go ahead.
I'm grateful to AIOS WAS and Mohita ma'am for the opportunity to share our experience of management and surgical outcomes of pediatric retinal detachment associated with FEVR. And my co-author is Dr. Vishal Agarwal. The purpose of this study was to report the clinical features, management, and prognosis of pediatric RD associated with FEVR. This was a prospective intervention study at SMS eye department. And I will not go into the details of the disease, but it was first described in 1969, and the main hallmark is an avascular peripheral retina. It can be both syndromic and non-syndromic with genetic predisposition. The classification was given by Pendergast and Tressel. So because of the variable presentation, it is often unrecognized and diagnosed incorrectly. Hence, we wish to report our 14 eyes of 13 cases between the ages of 6 to 18 years. And they were, prospectively screened and followed up from January 2013 to July 2019. All had macula involving retinal detachments in one eye, and 13 had peripheral avascular areas as well. They underwent intensive investigations, and history regarding prematurity, antenatal complications, and trauma was also taken. There are a variety of presentations that we had, including subtotal RD, the peripheral avascular retina, the RRD, the combined RD with PVR and macular drag. And all these findings will be described in greater detail if I had more time. But coming to the results very quickly, all 14 eyes underwent surgery, and 4 with scleral buckling and 10 with pars plana vitrectomy with silicone oil with or without preoperative anti-VEGF. In interest of time, I'm going to skip the surgery, which is a very complex repair of the pediatric RD here. And so coming to our results, 13 out of the 14 cases had attached retina at the final follow-up, and the final visual acuity improved in 13 eyes. And the best visual acuity was 6/18 in 2 cases. And the siblings were also screened. We have a variety of our post-operative pictures as well, showing good results. And there was no leak after the laser also. These are the patients showing the post-buckling reattached to retina, and post-surgery pics after the pars plana vitrectomy. Coming on to just the conclusion, which is that strong suspicion and thorough clinical examination is needed. And this particular case series was to summarize that the early diagnosis is of paramount importance in view of the progressive nature and poor prognosis, but if diagnosed early, they can have very good clinical outcome. Thanking you all for a patient audience.
Lovely.
Thank you so much, ma'am. Thank you to all the chairpersons and the
The
speakers.
session was beautiful, and I can see Sir there for the next session, Dr. Mahipal sir. So everybody wind up, and I think there was a lot of science discussed. Lovely, and see you all in the next session.
Thank you to all the chairpersons and speakers. It was a lovely session, very informative. Thank you very much. Have a good evening. Thank you.
Thank you.